Dr. Goran Helgason joined Advanced Vision Care's medical team in 2006, and he performs our ICL, CLE and cataract procedures.
Multifocal lenses have been around for a while. I implanted my first multifocal lens in the late 90s, actually. But they have evolved and getting better as every other refractive technology today. But we have a few different kind of multifocal lenses on the market. We have refractive lenses. We have another sort called diffractive lens, and also apodized diffractive lenses. And I will speak a little bit about these different kind of multifocal lenses. Most often we have a central zone for distance correction, and the next zone will be for near, and then for distance and near, and so forth. So they all separated distance and near focuses. With a smaller pupil, you will the distance will dominate. So the drawback of these lenses are that if the pupil is very small, you just have to you can't use the near vision sufficiently. To make things better, the diffractive technology emerged, and then you have instead of having separate focus for near and far, every step will direct the light in a near and a far focus. So this lens has the advantage of not being so pupil dependent. So if you have a small pupil, it doesn't matter so much. If the pupil is big, it doesn't matter so much. So it's more or less pupil independent. But what you have instead is that you get probably more halos with this kind of technology than the refractive technology. So what that leads on into the third sort of lens that will be more or less a compromise between the refractive lens and diffractive lens. Each step diffracts the lens, the light of the image into two focus, one near and one far. But the steps are increasingly smaller in the periphery of the lens, and that makes it more distance dependence the larger the pupil gets. So when the pupil is small, you have the ability to read better, but when the pupil gets larger, for example when you're driving or seeing it at a distance, distance will dominate. So what you can see here is the same picture as before, just in absolute terms. You can see the light energy will be the same for near, independently of the pupil size, but when the pupil gets bigger, the more of the energy will be directed for distance vision. This is the apodized diffractive lens. It's called Restore. And you can see here on the defocus curve that you have a peak for distance, and then you have another peak around 40 to 50 centimeters. Another issue with these lenses is that it's a little bit complicated with the optical structure, and it will compromise the optical quality a little bit. So what they've done is to do these lenses is aspherical, and that will add to the optical quality of the lenses. The first generation of lenses were just spherical, and the optical quality was not as good as the latest versions of these lenses. You can see it in this picture, that contrast sensitivity increases when you add the sphericity of the lens compared to the older spherical one in green. As you understand, this is a technology where we take out the crystalline, the natural lens, and replace it with an IOL, exactly as you do with cataract surgery. So obviously cataract patients is one group that can have these lenses, but I think for most of the cases, and most of the cases we do, they have no cataract and just presents with presbyopia. The patients with, that had multifocal lenses, contact lenses before, they will be very likely to tolerate a multifocal IOL. Some of patients are too technical for this lens. We have, for example, the teacher type and the engineering type, who was prone to analyze the situation all the time. And I think they are not really so happy as the easygoing one with the lenses like this. So that's what I call the perfectionist in this slide. You will also exclude patients that will not under any circumstances accept glasses, because sometimes some of these patients need glasses for reading sometimes. If you have another eye disease, it's not a good option, because anything that compromises optical quality will make these lenses perform worse. Another thing I'll point out in the lower side of this, down at the slide, that former character refractive procedure can be disqualifying for having a multifocal lens, especially if it's done several years ago. And that depends on patients that we sometimes induced aberrations and the optical quality wasn't so good. Reading distance and especially intermediate distance gets better with time. Some people also complain of the reading distance, especially in dim light. So to point out that good light condition is important. It's that we should always do, because they need good light. So you have to urge the patients to be patient. And it's not easy. But every drawback, everything that I've been telling you now, if you tell the patient beforehand, it's much easier for them to accept it after the operation. So if it's a price to them, they will kill you. Inevitably, all these lenses produces halos. So because of the ring structure in the optics, you will have halo phenomenon for at least some weeks after surgery. And Jonathan was also talking about the halos in the intracore treatment, and that people get used to it. So that is called neuroadaptation. So if you have seen this for some weeks, the brain will start to eradicate the sensation of the halo. So as with the ICL movie, this is real time. So what you start up with is dilating the pupil. You have a big pupil, And then you do probably 2 or 3 cuts. One main incision, this is what's going on now. The other 2 was just what we call side ports. Then you fill the anterior chamber with viscoelastic, and what comes next is you have to do what we call a capsulorhexis. You also can inject some anesthetic into the eye. As you can see, the patient can move the eye during the operation, but have to fixate on the very strong light from the microscope. What we see here is what we call the capsulorhexis. It's around here in the lens capsule, so that we can approach the crystalline lens that is underneath and inside the capsular bag. The lens is a little bit fixed to the capsular bag, so you have to do something called hydrodissection to loosen the lens and to make it approachable for your phaco machine. We don't have at this point any laser doing this, so we have to do it the old-fashioned way with ultrasound and the phaco technology. In this situation, when you have a clear lens, you don't use too much ultrasound. Actually, it's mostly suction, because the lens is so soft. So again, this is real time. You're consuming that lens quite quickly because it's so soft. Then you have some cortical material left that is sticking to the capsule, which you really shouldn't take out with ultrasound, and you uses the what we call the INA, inspiration aspiration tool, for removing the cortex. So there's the cortex coming out, and now we have an empty bag. So where the crystalline lens was situated before, it's now empty, and will be filled with first viscoelastic again to expand the bag before we can put in the lens. And in this case, it's again a restore multifocal lens. It's injected into the eye, and you see it's like a roll, and then when it's getting injected into the eye, it will expand. You see the haptics here at each side, and the central optical part. And it centers quite well into by itself. I don't know if you can see the rings, the ring structure of the multifocal lens in the picture there. You also have to remove the viscoelastic stuff out of the eye, otherwise the intraocular pressure will be very high the day after surgery. So this is over now, and thank you for your attention.